here we go. And I'll be sending a copy of this session to everyone who's registered. So in case you missed something, you're free to go back and, review it at your own leisure. So without further ado, Sajad, Evan, take it away.
Thanks so much, Vanessa. So before we dive in, I'm going to turn it over to Sajad for the beginning of the presentation. But before we dive in, I just wanted to give a little bit of context about who we are and what we do. So Research Informatics is a division within ITS that, as Vanessa said, is charged with supporting the research enterprise with electronic patient data. So what that means is that we spend the majority of our time working with researchers here at Cornell, and figuring out how to best help them with data from the electronic health record, whether that's data that's getting abstracted automatically or entered or done by hand through chart review, in addition to sort of other large-scale patient data efforts. So sequencing results, REDCap, a lot of other efforts. So we had in place a number of sort of data repositories before the pandemic, and then on March 13th, everything changed. We had to sort of rapidly reconfigure a lot of our existing methodologies and approaches to address the specific data needs that came up around the pandemic. So that's what we're going to be talking about today. Sajad's going to be doing the majority. I will be chiming in here and there. So without further ado, I'm going to turn it over to Sajad.
All right, awesome. Thank you, Evan, and thank you, Vanessa, and thank you, everyone, for joining us on this rainy Tuesday, assuming everybody's in New York. So today, as Evan mentioned, we're going to go over our response to COVID-19 since the beginning of the pandemic and how we are supporting our researchers to really explore patient data and use the patient data to be able to answer any questions that they have regarding their projects. I'll go over our existing infrastructure that we call ARCH, stands for Architecture for Research, Computing, and Health. I'll dive deeper into the COVID institutional data repository, COVID IDR. I'll talk about how we put it together and any regulatory standpoints of the IRB protocol guidance on that end. And we will go over the I2B2 tool and how we implemented the data elements from specific to COVID patients and how we can utilize that to also interact with the patient data. And at the end, we'll take more questions and comments. And as Vanessa mentioned, if you have any questions, feel free to stop me by raising your hand or drop the question in the chat. And we will also have breaks in between to be able to answer questions. All right, so ARCH, Architecture for Research, Computing, and Health. It is the suite of tools that a Research Informatics team supports through CTSC in collaboration with our hospital and also some of the college and the departments here at our college, including PHS, really trying to answer the biggest questions when it comes to projects that are using patient data, whether it be prospective or retrospective data. Most of the time, the main question remains that what kind of tools should be used to interact with the patient data? And that's really up to the project, and also that really depends on the level of detail that the project requires to explore the patient data. We have data at the college level. It can also, the tools can also support citywide, statewide, and with certain regulatory approvals, we can also expand to nationwide patient data. And for today's purpose, we will only focus on the institutional data repositories that we put together in our institutions. We have about 20 or so of these currently working. We collaborate with many departments in our institution to set up different types of institutional data repositories to support different projects and different questions. And for today's purpose, we will only focus on the COVID institutional data repository. Sometimes beginning of April, only a few weeks into the pandemic, we stood up this data repository that originally included patients who tested for COVID-19. And then later on, we expanded it to all the patients who have had any visits with our cough and fever clinic. We also included patients who are symptomatic, using their diagnosis codes to identify these patient cohort. And also we all included patients who have had any diagnosis of COVID-19 in their medical record. I think last time that I checked, we had about 150,000 patients in our data repository. And these patients are from East Campus, which is our hospital in 69th Street. It's been a while, I haven't been there. On the 69th Street, and also we include Lower Manhattan Hospital, as well as our physician organization offices scattered through Upper East Side and throughout Manhattan. We also include data from our affiliated hospitals, Walcott affiliated hospitals at Queens, and in near future, we are planning to bring in data from Brooklyn hospitals. And sometimes in the future, we are working with the Columbia and our affiliated regionals to include their patient and their patient data into our institutional data repository. The setting that we are looking into are both hospitalization, inpatient hospitalization in the hospital, as well as the emergency visits, and the outpatient visits at the physician organization. So when it comes to putting the institutional data repository in general, including the COVID IDR, our biggest challenge is to identify where to get the data, and also how to get that data and how to put all these disparate sources together to make it usable for our end users. Here we are getting data from Epic, Allscripts, and RedCap. As you may know, a few weeks ago, we went live with Epic for our both inpatient and outpatient settings. So we are now heavily relying on Epic to get our patient data, but also we are incorporating legacy data from Allscript, which used to be our inpatient electronic health record system, as well as a few manually collected data that we worked with one of our teams, Dr. Goyal and Dr. Choi, who collected data from for COVID patients in the RedCap instance, and we were able to bring in that data also into COVID IDR. As I mentioned, we are going to include Brooklyn data. They're using Cerner as their electronic health record systems. And we also, in very near future, we are gonna incorporate open specimen data, which is our biorepository system in our institution. And many other sources that we utilize to complement the data that we could not get from the sources that I already mentioned. So once we are able to homogenize and bring all this data together, we try to put them in different domains. Domains include patient demographics, any diagnosis for these patients that have been recorded in these systems, visit level data. These visit level data are not only specific to the visit that they were diagnosed with COVID, but also we go back 5 years in their medical record and include any visit that they had or any diagnosis and past medical history that they had, and incorporate that into the COVID institutional data repository. So now, as an end user, you will be able to look at the continuum of care for these patients since 5 years ago and be able to use that valuable resource to answer your questions regarding these patients. So the type of use that we see often, and I start with the most common one, is the research. Of course, there is a novel disease, and there is not much that is known about this. So we've seen an influx of researchers and grants being submitted to study and use this type of data to be able to answer a variety of questions. Of course, that has to be vetted by the IRB office, but also we do see a lot of our end users are physicians who work in a unit, and they're just trying to understand what's going on in these units, what were the changes before and after pandemic, and how can they improve the quality within their unit, within their department, and within the institution. So we see a lot of clinical operations and quality improvement projects coming down the pipeline and using this valuable resource. So that's the process of getting your hands as an end user on this data. We, as I mentioned, have done this for the past 5, 6, if I'm correct me if I'm wrong, but within the past 5, 6 years that we've existed as a team in the institution, working with other teams to set up institutional data repositories. You normally will end up speaking with one of my colleagues, one of our business analysts here, to really go through the details of your data, your project, and evaluate whether COVID IDR is the best fit or any of the other tools that we went over. And also, we strongly suggest having a biased statistician on the team, because at the end of the day, they will be the ones who are touching the raw data that comes out of this data repository. And we'll be able to go over all of these details and familiarize the study team with the data repository, and try to assess the study team skills in terms of whether the project requires some of the resources that we offer at Research Informatics, using our software engineering team to extract the data or manipulate the data a little bit further to make it easier for the study team to use. We also make sure we are checking all the boxes when it comes to compliance. As you know, patient health information is highly sensitive. So we are really strict about it in terms of we make sure that the language that is used in the IRB protocol matches what needs to be described, and describing the institutional data repository properly. And we also, and as Evan will go through this later in this project, we have boilerplates and templated language that will help you to submit an IRB and check all the boxes that needs to be checked to use this data. We have data access agreements in place, and really we try to be the honest brokers of the data, as we were tasked by the leadership, privacy office, and the tracking and core team to oversee the flow of the data from all these source systems all the way to the hands of our end users. Once we go over all of those compliance reviews and the informatics consult, it comes to the question of how do we deliver the data to you. We started giving direct access to our users. That's mostly for our key faculty and staffs, and the ones that are a little bit more technically savvy, to be able to actually write the queries themselves against our source data, to be able to pull the data into their own machines or software, statistical software packages, to be able to use the data. If the study team is not capable of doing that, we are more than happy to allocate our resources at Research Informatics. We have a huge group of software engineers who are tasked to not only set up infrastructures like this, but also assist our researchers to create custom reports to be able to extract the data for you. Of course, that has to go through our normal queue of all these requests and custom reports that are down the pipeline, COVID and non-COVID related.
Awesome. Thank you so much, Sajjad. I'm gonna take over for a little bit and go a little bit further into detail about what the repository actually looks like and what the process is to secure data. Sajjad, do you mind if I share my screen briefly?
Absolutely.
Thanks. All right. So up until now, we've been showing you a PowerPoint presentation for the most part, and I'd like to. Is my screen coming through okay here?
Yep.
Great. I'd like to show you guys what the data actually looks like. So we set up the COVID institutional data repository as a SQL Server database. SQL Server is sort of an enterprise platform for storing large-scale data, big data sets. And essentially what it is a series of tables in SQL that you can query. If you know SQL, if you don't know SQL, you can download them and open them in Excel. And each table corresponds to one of the domains that Sajjad was presenting earlier in the slides. So we have one table with a row for every patient with columns for demographic data points. We have one table with a row for every visit, every diagnosis, every med, et cetera. And the idea here is for people to sort of stitch together the tables based on input from their biostatistician to address a specific analytic use case. So one use case might call for, you know, a data set with a row for each patient and columns with dichotomous variables for various comorbidities. Another might call for a row for each hospitalization with columns for whether or not people were intubated. Another might call for a row for every ICU stay. It really depends. So the data structure that we set up, we tried to make it as flexible as possible to accommodate a broad variety of use cases. And this is really what it actually looks like. So you can see here I've blanked out some of the columns that actually have sensitive patient data because I am not particularly eager to share patient data on a Zoom call with 41 people. But you can see here it's one row per lab value, you know, with columns indicating who the patient is, what the visit was, when the result came back in, as well as what the order was, what the lab component was, and what the result was. Similarly, we have, you know, diagnosis data. I would imagine a lot of you on this call are looking at this bit of software and all the little buttons up here, DMX, I thought that was a wrapper. I don't know what half those buttons do. You don't need to use this program to interact with the data. You know, we recognize that science doesn't happen in SQL Server Management Studio. Science happens in SAS or Stata or R. So we also have a number of sort of connection scripts that we've made available that let you bring the data in directly to a statistical environment and start querying it there. So this is the script to connect to the IDR from inside our studio. As you can see, it is literally, you know, 2 or 3 lines of code. And you can run your SQL queries to bring the data in, and then you end up with the data frame in R that has all the data from the server. So a SQL Server is just sort of where we house it. It's up to you where you want to analyze it and use it. I just wanted to go over that briefly before diving in further. So as Sajjad mentioned, we really set this up to address, you know, both clinical operations and research use cases. You know, especially at the height of the pandemic, the Division of Pulmonary and Critical Care Medicine, you know, we're working pretty closely with, you know, Dr. Ed Shank and some of the other folks there to provide sort of as up-to-date data as we could on, you know, ventilator usage, stuff like that. But ultimately, the purpose of this is to facilitate research. As Sajjad mentioned, there are multiple ways people can get access to this. You can submit a request form, and I'll show you the link where you can request access and get access directly yourself. If you're comfortable with SQL or R or Python, you can dive in right away and start querying the data. If you're not comfortable with that and instead you want a sort of custom, you know, graph report where you say what the rows and columns are, we can also do that. You know, it'll take a considerably longer amount of time, and it'll depend on all the data being available in the IDR, but that is possible. So there's a data request process in place, and I can put this link in the chat. But we have a request form on my help desk where you can request access to the COVID IDR. I'm actually going to put this link in the chat right now. Let's see, everyone. There we go. And you could just hit request user access. And don't be scared away by the mention of the fee. That's only if you want to create a totally new data repository. But you would request user access. You would say, I want access to the COVID RDR. So we call it COVID IDR, RDR, more or less indistinguishable. And we can help fill out this form if any of these other questions are still up in the air. As part of the form, part of signing the form, you are attesting to appropriate data handling and use. You're asserting that you won't put the data up on Facebook, Instagram, or Flickr. I don't think anyone's used Flickr in a long time. I don't even know if Flickr's still around, but you can't put the data there. And you know, once we've reviewed your request and we'll approve the, you know, ascertain that the IRB protocol is approved, you know, that you have a legitimate use case, we'll provision you direct access. We also have a data request form that we can provide that lets you know how to request the sort of rows and columns level reports. But we also have a SharePoint site that contains a lot of the details for this. So the SharePoint site really has, you know, a lot of the documentation. Oh, that's a good start. There we go. This answers a lot of the questions. It goes over a lot of the material that we've covered here today. It includes links to the RDR request form. I'm gonna put this link in the chat as well, so folks have this if they'd like. You know, it goes over, we also have a data dictionary with really sort of granular information about what each column means in each table. We also have a sort of more high-level description of the domains that are available, as well as the scripts that I mentioned earlier, detailing how to connect both in SQL Server Management Studio and in SAS, R, Python. And as Vanessa said in the chat, she'll also be sharing those links by email after the session. So this SharePoint site is really designed to serve as a sort of a repository of information about the IDR. You can see here a screenshot of the site, which is we gave you one better, the actual site. So we've seen a lot of use here. We've seen a fair amount, a few thousand queries, probably provisioned access to 40 or 50 people since the start of the pandemic, and it's supported a pretty fair amount of research. I'm just going to skip ahead briefly. These are sort of 5 examples of papers that have been published in the past few months using data from the COVID IDR that I thought were sort of particularly emblematic. Vanessa, I can also provide you links to these papers so we can circulate these in the email after the session as well. But we've really been able to support people looking to address multiple disparate research questions. So, people looking, people from hematology and oncology, looking to assess the impact of COVID on patients with cancer and looking to see if patients with cancer have, notably different trajectories from patients without cancer. Looked at the, the risk of stroke in COVID patients versus flu, trying to see if there's anything specific about the coronavirus that predisposes people to stroke and as opposed to just regular respiratory disease. This paper in the New England Journal of Medicine sort of went over the characteristics of our cohort of COVID patients. And there's a lot more in the pipeline. We've been really privileged to be able to support some of this research, and we lead the groundwork, and the credit ultimately goes to the clinicians and biostatisticians who developed the analyses and conducted them. Really, again, privileged and honored to be part of that work. Just briefly before we finish up with the IDR stuff, the IDR was aggregated under its own IRB protocol. So the IRB has requested that all sort of registries or data repositories have an IRB protocol governing collection of the data, and we have sort of templated language available. Again, this is there on this SharePoint site for people who want to do research using the IDR. We recommend that people include language here so that the IRB knows where you're going to be getting the data from. We can also, if people are collecting novel metrics as part of their study, let's say, for example, I want everything from the COVID IDR, but one of the data points I need requires manual chart review. We can also take the results of that manual chart review and make it available in the IDR to others, much as we've made the data from the Division of General Internal Medicine REDCap project available for folks who are able to access that. And we have IRB language here to cover that as well. We also request that anyone, when publishing papers using this data, request some, put in something to the acknowledgement stating that we're supported by the JCTO and the CTSC. So that's pretty much the majority of what we wanted to share about the COVID IDR. I want to pause briefly to give folks an opportunity to ask questions. As we said earlier, please feel free to raise your hand using the Zoom function. You can type your message in the chat, whatever you prefer. So I'll just pause for a couple minutes to allow for questions. All right. Either we did a very good job of presenting that, or it was so confusing that folks' minds are still spinning. I guess we can sort of continue to start to segue into some of the other aspects of our response to COVID, specifically related to I2B2. But please feel free to keep your questions in mind, and you can drop them in the chat, and we can address them after we move on to the next topic. So with that, I'm going to stop sharing my screen, and I'm going to turn it back over to Sajad.
Sorry about that. Let me just bring up the presentation again. All right, awesome. So before I jump right into I2B2, I'll try to cover as much as we can for I2B2, but I'll do a shameless plug for our monthly ARC workshops, where we actually go over all these tools that I earlier showed, including REDCap, Super REDCap, and I2B2. And also we do have our one-on-one training sessions for anybody who's interested in using I2B2. So if nothing makes sense or you still have questions and you want to learn more about I2B2, feel free to email us, and I'll be more than happy to help you learn more about I2B2. But for those of you who are not familiar with I2B2, I2B2 is a tool that was developed at partners by an NIH grant. We adopted I2B2 for our institution. It is a self-service cohort discovery tool that answers questions that starts with how many. For example, if you want to know how many patients are diagnosed with certain disease, diabetes, in a specific year, you will be able to use I2B2 to answer that questions. And when it comes to COVID, of course, the possibilities are endless in terms of the questions that you can ask pertaining to COVID. I'll go through I2B2 and I'll show you the overall concepts and things that you can create your query and build your query with. But specifically for COVID, what we did was we adopted the NCATS Act ontology to be able to create queries for COVID. It's just the list of related concepts and terms that are mostly queried or asked by our researchers. It is worth noting that anybody can access I2B2 with a great length to be able to de-identify the data in I2B2. And anybody who's part of Weill Cornell and or the hospital has a CVID or email address at the hospital is able to access requests for I2B2 and be able to use this. So I'm gonna actually do a demonstration. So that's the login page. Once you have access to I2B2, you will be able to use your CVID and password to log into the data. And that is an interface for I2B2, slightly 2000 because I forgot to mention this tool was created around 2000 at Partners by Harvard. So I'll quickly go over some of these concepts. And I know we have about like 10 to 15 minutes and I want to leave some time for the questions. Essentially, let's say if you want to ask a general question of, well, how many patients have confirmed cases of COVID? All you have to do is find the correct place to navigate through these terms and drag and drop your concept or related terms. For example, here, I'll go through the ACT ontology for COVID-19 and under diagnosis, I'll be able to find confirmed cases, suspected cases, or symptomatic. Before I run the query for confirmed, I just want to show you how does that work. So it is feeding off of all the data sources that we created COVID IDR. It is just another interface to interact with the data. For example, in COVID IDR, you had a table with all the diagnoses. We are able to aggregate the data and put it under these related terms and use the diagnosis codes here, J20.8, for example, the ICD code related to this diagnosis and be able to present that to the end user and sort of alleviating the pain of writing a query to answer simple questions. Again, you answer questions that starts with how many. So for example, how many patients have confirmed cases of COVID-19? All you have to do is just drag and drop in here. You run the query and you will be able to get a number. You will not get patient level data. You will only get the aggregate number of the patients that exist with the criteria that you indicated. But you are able to get the list of patients if you have an IRB approved. All you have to do is just submit your approved IRB along with the name of the query through My Help Desk, and you will be able to actually release the patient MRNs and identifiers to you as long as you do have an approved IRB and covers your question. Evan, do you want
to we'll be circulating the link to the ITB2 request form afterwards, and that form is it's both how you request an account on ITB2, and it's also how you request a list of MRNs. So there, you'll see at the beginning of the form there are a couple of choices. Do you want to request an account or request a list of MRNs you've run? But generally the idea is that you run the query. Once you're satisfied that you've identified the patients of interest, you can then submit a request to us, and we'll generate and send a list of MRNs to you.
All right, awesome. Thank you, Evan. So as I mentioned, I won't go into the details. We have other workshops and training sessions that we can go over all of these. But let's say you wanted to ask another question. So how many patients who were confirmed with COVID were intubated through their respiratory therapy management? So I would be able to utilize the same ontology and now add this secondary additional term here and run the query again. You can not only use COVID-related terms, but you can also incorporate their past medical history. For example, you want to see how many of these patients had a certain diagnosis. For the ease of use, we'll just use, let's say, diabetes. And I'll use the ICD-9 codes for now. Feel free to add the ICD-10 codes for this diagnosis. Of course, the more specific you are about your questions, the better of the results you will get. And there are some nuances that you have to keep in mind when you're defining your query and defining your questions and trying to create this quote unquote phenotype for your criteria. So for example, for diabetes, I'm just going to use the ICD code 250 for now. There are other ways to identify diabetic patients. You could use laboratory results as a proxy to target these patients. But for now, I'm just going to use anybody who had a diagnosis of 250, ICD-9 250 in their medical record to see how many of them were not only confirmed with COVID, but also were intubated. So if you remember, we had about 400 in our previous results. This number will be probably a little bit less than 400 for the patients who had a history of diabetes in their medical record. Generally, these queries should not take that long to run. If you have any problems with the queries that you're creating, feel free to just send us an email and we'll be able to troubleshoot that. But also, if you have just like a general questions that you want to create any queries, we are able to help you set up your query in a way that it answers the questions that you're trying to ask.
So there's one really important point about ITB2. I just want to break in really briefly and mention this. That we're giving people access here to an immense amount of patient data without requiring an IRB protocol. So, you know, I even though all you can get out of this is counts, it's still theoretically possible to run, you know, a series of queries designed to drill down pretty you know, far into detail about specific patient data. So in order for the IRB to be comfortable with this, we had to implement a couple of changes to the underlying data that this was feeding off of. So Sajjad made earlier what I thought was a really great point, which is that this is feeding off of the same data as the COVID IDR. It's just a different way of interacting it. But the key difference here is that in order to make this available to anyone without an IRB protocol, we had to de-identify the data. And the HIPAA standard for de-identification of data is pretty exhaustive. It doesn't just include, you know, replacing MRNs with subject IDs or, you know, getting rid of names. You're also not allowed to include dates of service in a de-identified data set. The inclusion of an actual date of service makes it no longer de-identified. So in order to make this available to everyone, what we had to do was obfuscate the dates, you know, or scramble the dates. So what we do is for every patient, we pick a random number between 1 and 364, and we shift all their encounters back by that number of days. So what that does is it preserves, you know, sequentiality, but it effaces objective temporality in that, you know, there's no more sense of, you know, how many patients were intubated in April of 2020 versus June of 2020. We can't provide that granular data. What it does preserve is the sequential nature of events. So ITB2 has some features in that temporal constraint that let you say how many patients were intubated and then had a respiratory rate over a certain value, or how many patients were intubated and then had, a PaO2 below 70, stuff like that. So you can still do those, but you're not going to be able to get out of I2B2 the exact same counts for temporally bounded queries. We do, if you have a use case that depends on, getting the time data really sort of exactly as it was, you can let us know, and we'll work with you to run that query. We have another version of I2B2 that's not de-identified in that way, but the default version that we make available to everyone, that's an important sort of caveat to keep in mind.
Thank you, Evan. And also I want to add that to preserve that privacy concerns that Evan brought up, these are estimate counts. It's a plus or minus 5, if I'm not mistaken. So that's just another layer of filters that we include to make sure we are compliant with all the privacy issues. So that's about it in terms of what we wanted to present. So we have about 5, 7, 8 minutes. So if there's any questions, either ask it right now or feel free to contact us via the emails and all the other means of contact that we have here.
Guys, while we're waiting for questions, I just thought this would be a good opportunity to kind of plug. You guys have monthly ARCH sessions, correct? I think it's the last Thursday of every month.
That's correct. That's correct. Yeah, thank you so much, Vanessa. Yes. So any questions that you have that are not answered here, and if you want to learn more about I2B2 and any other tools that we offer as part of ARC that I presented up here, feel free to drop by our monthly workshops that are last Thursdays of every month. Keep an eye on for an announcement. We send out a few days before the workshop itself. We usually cover REDCap and I2B2, and we often have a special topic every month. Sometimes we go over I2B2 COVID-19, sometimes we go over the COVID idea itself or any other tools, including Super REDCap and other features that you may not know about.
Yeah, and we send that invitation to those workshops to a few listservs. So in the email that I send out to everybody following this session, I'll post the listservs that we usually send it to. So probably the largest one is community, since that reaches to most people in the college, and you're free to join it and get not only information about these sessions, but just events that are happening around the college, just different webinars that are going on. So it's really a great listserv to be part of, but there's also an I2B2 one and things like that. So, if you're not part of any of the listservs that we send it to, feel free to reach out to me and let me know whether you want to be a part of one, and I can walk you through how to sign up for one that's most appropriate for you.
Awesome. Thank you, Vanessa. All right.
Cool. All right. Well, it looks like we don't have any questions. But yeah, as Sajad said, please feel free to just reach out. We're here to help. Any questions you have about using EHR data for research, any of these tools, you don't even have to have like a really fully fleshed out question. If you're just sort of looking to do a project and you're not sure, what tool is the best fit. Is it I2B2? Is it REDCap? Should I just, start typing random numbers into the MRN section of Epic? We're here to help. That's really what we're charged with, by research leadership. So always feel free to reach out, arch-support@med.cornell.edu, with questions about any research project that needs electronic patient data. All right.
Well, I don't see any questions, but again, we'll be sending some follow-up information with the contact info for that Sajad and Evan have provided today. And again, just give me maybe till the end of the day tomorrow morning to just process this video, and I'll make sure that that is also included as part of the follow-up information. But thank you guys so much for taking the time to participate in the session. Evan, Sajad, thank you for hosting it. A lot of great information today. And I know it's a jury day, but everyone have a good one.
Thank you very much.
All right.
Thanks so much, everyone. Really appreciate your attendance.
All right, bye-bye.